Hello everyone. Today I'm going to talk about trauma surgery. Now, which are the most common sites in the mandible for the fracture? So it's first the condyle, then the angle, and then the symphysis. What are the different kinds of fractures? They can be green stick, simple, comminuted, and compound. Contemporary treatment for mandible fractures that are displaced and mobile is with open reduction and internal fixation using titanium bone plates and screws. So we'll be talking about what are these in detail as we move further in the topic, and also what is this internal fixation, what are the screws, plates, and all of it. So mainly whenever there is a mandibular fracture and the fracture is displaced and the fracture is mobile, it is usually treated with open reduction and internal fixation. So this is the diagram you can see here. There are titanium bone plates and screws that can be seen. Now, if the patient has teeth, the occlusion is used to guide the surgeon during the repair of the fracture. Other methods of repair include lingual splinting in pediatric patients. So lingual splinting is not invasive as compared to the other procedures. This technique is reliable, non-invasive procedure that dentists may consider in selected cases by referral to an oral and maxillofacial surgeon. It also limits the discomfort and morbidity that can be associated with maxillomandibular fixation or open reduction and internal fixation in pediatric patients. So first, let me show you the picture. So here you see this is intermaxillary fixation, and these are the screws that are being used. So here what happens? The quality of life is compromised for a few days till the whole jaw recovers. Whereas this is the lingual splinting that can be seen over here in the cast. And here, this is the fracture region. You can see the fracture. So in general, lingual splinting is non-invasive and it can be done by a dentist when it is referred by an oral and maxillofacial surgeon. And it also limits the discomfort. But to treat complex or multiple mandibular fractures, the bones will need to be surgically exposed and it needs to be repositioned and stabilized. So suppose, let me draw. Now, there is you can see a light crack. It can be fixed without invasive methods. But if it is an accident or a trauma case where the pieces are being displaced, then that part needs to be exposed, it needs to be repositioned and then stabilized. It is going to be only stabilized when the screws are being used or plates, depending upon what is the condition, and sometimes even wiring of the jaws. So here you can see the wiring, plates, and screws. Now coming to how do we diagnose these mandibular fractures? They can always be identified on a panoramic radiograph. Suspected fractures should always be visualized in at least 2 radiographs. So it can be in panoramic view, Townes view, posterior anterior skull view, and lateral oblique view. So for different kinds of fractures, different views are being used. So let's talk about each. Waters view. So what does Waters view use? It shows facial skeleton and maxillary antra. Avoid superimposition of the dense bones of the skull base. Indications mainly for investigation of maxillary antra and detection of middle face fracture. Okay, so it is mainly focusing on the maxillary antra and the detection of the middle face fractures. PA view, posterior anterior view, identifies trauma, pathology, or developmental abnormalities. Now, mid-face fracture are best evaluated by computer tomography scans of the face. 2 orientations, axial and coronal, are needed fully to evaluate fractures of the midface, which can involve maxilla, zygoma, nose, and orbits. Maxillary fractures are described as Lefferts 1, 2, 3. As with mandible fractures, midface fractures are described by the bone involved as simple, compound, or comminuted. Maxillary left foot fractures, orbital fractures, and zygomatic fractures usually require internal rigid fixation. Isolated zygomatic arch fractures can often be reduced with minor surgery without use of bone plates and screws. So if it is just an isolated zygomatic arch fracture. So this is the zygomatic bone, right? This is the mandible. So if there is a fracture over here, then it can be reduced with minor surgery without the use of bone plates and screws. Simple nasal fractures can be repaired with internal and external splints. Now, this is green stick fracture. This is simple fracture. And this is comminuted fracture. And this is compound fracture. So these are the different kinds of mandibular fractures. Okay. Now, let me use my pen. Okay, it's not working, so let me just use my cursor. Give me 1 second. Okay, I guess now it works. Okay. Evaluation of the patient with a dentofacial deformity is guided by the principle of balance and symmetry. Orthognathic surgery is accomplished to correct, see, orthognatha. Gnatha is nothing but jaw, right? So orthognathic surgery is accomplished mainly when there is like discrepancies, like the jaw can be too forward, too backward, or there is no symmetry. In those cases, that's when the surgery is done, mainly to correct severe skeletal discrepancies that prevent appropriate dental occlusion, and most often complete in conjunction with orthodontics. That's why it's called as orthognathic surgery. So the jaw surgery, and then it's fixed with the use of orthodontics. Dental health and oral hygiene are important considerations in these patients. Patients are evaluated according to the normal facial proportions. Vertically, the face is divided relatively into 3 halves, relatively equal thirds. Horizontally, the face is divided into relatively equal fifths. Patient can be described as a concave profile or a convex profile. Now, so Angle's classification of occlusion is used to describe the dental arch relationships as well as the facial profile. Angle's class 1, normal dental occlusion with a straight profile. Angle's class 2 is retrognathic jaw. Here, the mandibular first molars and the canines are in a posterior position relative to the maxillary counterparts, and the face appears convergent, posteriorly convergent, that is retrognathic jaw, whereas in class 3, you see a prognathic jaw. Okay, so here you can see this is class 1, class 2, and class 3. Okay, normal occlusion. According to Angle, the mesiobuccal cusp of the maxillary first molar aligns with the buccal groove of the mandibular first molar. Canine relationship. The maxillary canine occludes with the distal half of the mandibular canine and the mesial half of the mandibular first molar. Line of occlusion, the teeth, so this is the line of occlusion, the yellow color. The teeth all fit on a line of occlusion, which in the upper arch is a smooth curve. It should be smooth curve. It should not be above it or below this, okay? So it's a smooth curve through the central fossa of the posterior teeth and the cingulum of the canines and incisors, okay? And in the lower arch is a smooth curve through the buccal cusp of the posterior teeth and incisal edges of the anterior teeth. There is alignment of the teeth, normal overbite and overjet, and coincident maxillary and mandibular midlines. So here this is class 1, here class 2, where you see the maxilla looks like it is protruding, here, right? See. And class 3 incisors, mandibular incisors are more, it's like a prognathic jaw, the right word to use. Okay, imaging. Lateral cephalograms are the main images used in the treatment planning for orthognathic surgery, although panoramic radiographs, anterior posterior cephalograms, and periapicals are taken as needed. Lateral cephalograms are the main images. Okay. Now, cephalometric analysis, when combined with facial evaluation, helps determine the jaw primarily involved in the deformity, direction of the growth of the jaws, and the most ideal procedure for patient's diagnosis. Now, the primary diagnosis in dentofacial deformity patients are maxillary hyperplasia, increase in number of cells, or hypoplasia, decrease in number of cells, mandibular hyperplasia or hypoplasia. Other common descriptive terms are orthognathic, that is anterior open bite, vertical maxillary excess when the maxilla is too long, patient has a gummy smile, horizontal transverse discrepancy when the patient is in posterior crossbite, macrogenia means the chin is too big, microgenia, the chin is too small. Some patients may have a vertical asymmetry in addition to the other diagnosis. Surgical treatment depends on specific diagnosis as well as facial evaluation. Generally, when a particular jaw is diagnosed as being deficient or excessive, the jaw receives a surgery to correct the problem. Surgical workup typically includes radiographs and cephalometric analysis and a prediction tracing, model surgery, and then construction of an acrylic splint to be used intraoperatively. Now, maxillary surgeries are referred to as Leffert 1 osteotomies. The maxilla can be moved forward and down. So the maxilla can be moved forward and down, and it can be it can be moved up and back. It can be segmented into 2 or 3 pieces to better position the occlusion. So maxillary surgeries are referred to as Leffert 1 osteotomies. Mandibular surgery is most often done during one of the 2 osteotomies, that is bilateral sagittal split osteotomy or vertical ramus osteotomy. The mandible can be moved anteriorly. The mandible can be moved anteriorly to correct the retrognathia or posteriorly to correct the prognathism. In addition, the chin can be moved using a genial osteotomy to correct the macrogenia or microgenia. So here you can see how it is being split over here bilaterally. Now this is before and after, where you can see the difference over here. Now, distraction osteogenesis has provided oral and maxillofacial surgeons much greater flexibility in treating difficult deformities of the facial skeleton. Patients with deformities such as cleft lip and palate and hemifacial microsomia have previously required difficult surgeries. Distraction osteogenesis involves cutting an osteotomy to separate the segments of the bone. So you can cut it, separate the segments of the bone, and application of a device that will facilitate gradual and incremental separation of bone segments. So this is the appliance that will be slowly, it will be activated according to the oral surgeon. Now coming to the facial pain. The differential diagnosis of facial pain includes pathology of the dental structures, muscles, joints, blood vessels, salivary glands, sinus, eyes, ear, central, peripheral nervous system. Pain has physiological and psychological aspects. Now, a little introduction of how to imagine this kind of pain is, for example, you touch something sharp. That's a kind of pain. But that pain is different from a headache, where you will feel the pain over like a diffuse kind of a pain. And similarly, when a person is suffering with any neurological disorders, you will see that they experience the pain in the hands and side of the face. That pain is different. And a diabetic patient is more prone to neuropathic pain in the legs, and there is numbness in the hands. So that kind of pain is also a type of pain, but it is different. So there is somatic pain, visceral pain, and neuropathic pain. Now, coming to pain types. So basically, it's best to describe it as three types: somatic, visceral, and neuropathic pain. Somatic pain is mainly, it occurs in muscles, bones, and soft tissues. Visceral pains comes from internal organs and blood vessels. Neuropathic pain can be mainly because there is some signal problems between central nervous system, peripheral nervous system, and it can include trauma, inflammation, metabolic disease, infections, tumors, toxins, and primary neurological disease. This is all you need to remember in this slide. That somatic pain is mainly, it is like a stabbing pain, and mainly because of the mechanism of action is A delta fibers, and visceral pain is due to C fibers, and somatic pain is pinprick kind of a pain, and generalized pain is visceral pain. And somatic pain is mainly because it happens in the muscles, bones, and soft tissues, and internal organs and blood vessels is visceral pain. Neuropathic pain, it's mainly radiating, specific, and it is due to some signal processing disorder, and it is examples is trigeminal neuralgia, post-traumatic neuralgia, and peripheral neuropathy. So for pain to be experienced from a physiological perspective, transduction, that is activation of A delta fibers, that is somatic pain, and C fibers, that is visceral pain, to the spinal cord or brainstem. Transmission pain information is sent in the CNS to the thalamus and cortical centers for processing of sensory and emotional aspects, and modulation must occur. The human experience of pain is the sum of all these physiological processes and psychological factors of higher thought and emotions. When a pain lasts more than 4 to 6 months, it is called as chronic, and the psychological aspects are especially important in patient treatment and management. Now, odontalgia secondary to deafferentation, that is, occurs as a result of trauma or surgery. So suppose there is an extraction done to a specific tooth, okay, and then patient started experiencing pain. That can happen because in the surgical site, there might be a hyperactivity, or there might be changes in the second order nerves in trigeminal nucleus. So it can happen because at the surgical site, there is an hyperactivity, or in the trigeminal nucleus. That kind of pain is called as odontalgia. Post-herpetic neuralgia mainly occurs after herpes zoster infection. It is burning, aching, electric shock-like, mainly treated with anticonvulsants, antidepressants, and sympathetic blocks. Ramsay-Hunt syndrome, it's very important. It is a herpes zoster infection of sensory and motor branches of facial nerve and eighth nerve, resulting in facial paralysis, vertigo, deafness, cutaneous eruption of the external auditory canal. Neuromas may occur after nerve injury. The proximum section of the transected nerve forms sprouts within the Schwann cells and other neural elements, can cause neuropathic pain. Now, burning mouth syndrome is most commonly seen in postmenopausal females. They complain of pain, dryness, and burning sensation in the mouth and tongue. And these resolve, usually 50% of the symptoms resolve over a 2-year. And there is also a change in the taste in these patients, and it is felt to be secondary to a defect in pain modulation. Hormonal therapy has not proven to be efficient, and anticonvulsants and antidepressants have not yielded consistent results. Chronic headache is characterized either as migraine, tension type, or a cluster headache. Now, next is temporal arteritis or giant cell arteritis is also important because the presenting symptoms are often difficult to differentiate from other causes of the jaw and head pain. So all this pain might look similar, but a physician and surgeon will be able to diagnose this better, saying like, okay, so there might be a pain in the jaw. It might be related to something else. And if it is confused with a jaw and a head pain, then if the patient is suffering with temporal arteritis, can lead to the blindness in the affected site. So that's all for today. And that, by that, I end the topic.